Thank you, Chair and Professor Akla. I think Kabhi squint is very common in this part of the world, and mostly the Pacific countries, and this is a divergent, intermittent divergent squint. And compared to the West, which has more of exodeviations. So it's a manifest outgrade deviation of the eyes, and the amount of deviation remains constant in all the portion of gaze, with no limitation of ocular movements. The types are primary, sensory, and consecutive. The primary is the one which is idiopathic, and deviation is in the deviation is the primary feature, and good binocular single vision in most of the cases. And idiopathic etiology and the mechanical factors and the innervational factors when compared to all types of squint. This has been the basic etiology, and development is a stage of exophoria, marked exophoria, and then this intermittency, and then you go for a constant exotropia. And the Duane's classification, all of you are familiar, divergence excess, wherein the exotropia is more for distance than near, and the convergence insufficiency exo is more for the near, and the basic both distance and near being the same, and the pseudo divergence excess, wherein the deviation is more in the distance gaze compared to the near gaze, and doing a patch test or other test will eliminate this, and it can, if it has true divergence, we plan for the true divergence, and if it is the other type, plan for the basic or more for near. The intermittent exotropia, as I told you, is more than 90%, and time of onset is between 6 months to 2 years. Sex distribution is common in females, and very unusually there will be associated myopia, and the precipitating factors: fatigue in health, bright light, and visual inattention. And presentation, as I told you, is in childhood, and straight eyes most of the time if it is compensated. Unless I think we go for the decompensated eyes, we don't interfere, and normally I think 2 to 4 years, I think I'll just come to that. Exotropia under common conditions of visual inattention, fatigue of health, and asthenopia is the commonest symptoms, photophobia, and they also occlude one eye, and the child tends to close one eye, and then micropsia, and also transient diplopia. Clinical evaluation: history, vision acuity, cycloplegic refraction, and cover test is done for both distance and near. And cover test has to be done for infinity also to get the true divergence excess in order to plan for surgery. Measurement, PBCT, and then AC over A ratio. Measurement of stereopsis, the simple thickness test will do in the outpatient, and test to differentiate between the true and simulative, which I told you, and measurement of fusional amplitude also is important. Non-surgical, optical, prismal therapy, and orthoptics. And most of the time we tend to do the anti-suppression exercise, increase the fusional range. And surgical is indications is when the deviation is more than the 50% of the time, that is a decompensated stage, and arthropic symptoms and development of suppression. Age after surgery, I think NAP advise early surgery. We normally do between 2 to 4 years, depending on their how much time they control. And jumper skin, some group they believe in delayed surgery. Choice of the surgery, type of exotropia, as I told you, which is true divergence excess, both bilateral lateral exosection, depending on the deviation, more than 50 prisms go for the third muscle, more than 75% go for the fourth muscle. And this is the standard textbook measurements which was shown earlier. Normally I think 1 millimeter of lateral rectus corrects about 3 to 4 millimeters of the resection corrects about 3 to 4 millimeters, 3 to 4 prisms, and resection about 4 to 5 prisms. And post-operatively, the eye can be ortho, and always you can face the consecutive ESO, then there can be a residual. And I think I'll just keep the slides. I think all are getting restless. We'll have to. This is the sensory exotropia. I think priorities that.